Thank you for joining us for this session, Infant Feeding Strategies to Prevent Food Allergy. My name is Kelly Cleary, and I'm the Medical Director at FAAR, Food Allergy Research and Education. And I'm joined by my colleague, Tiffany Leon, who is the Assistant Director of Training and Professional Programs at FAAR. For our disclosures, this session was supported by the National Peanut Board, and both Tiffany and I are employees at FAIR, Food Allergy Research and Education, which is a national food allergy nonprofit dedicated to increasing awareness, research, education, and advocacy for the food allergy community. So here's what we're going to cover today. First, we'll take a look back at how the guidelines around introducing food allergens have changed and highlight some of the big research studies that really shifted the way that we think about this topic. Next, we'll dig into the risk factors for developing food allergies, and then we'll wrap up with some practical strategies for prevention, starting with the maternal diet during pregnancy and moving all the way through to introducing allergens early during complementary feeding. So let's begin with a history of food allergen introduction guidelines, including those pivotal studies, but first giving a little bit of background information on food allergy. We all recognize that food allergy is a serious medical issue, with 1 in 10 adults being affected by food allergy and 1 in 13 kids being affected by food allergy, which roughly translates into almost 2 kids in every classroom across the United States. About half of the adults have reported having had a severe allergic reaction known as anaphylaxis, and about 40% of children have reported having a serious allergic reaction. But it's not just about reactions. There's also a very big emotional side to food allergy. For many in the food allergy community, it's not only about the risk of a reaction, but also the day-to-day anxiety and fear that comes with it. Think about that emotional toll of social isolation, the constant stress of having to read every label, carry emergency medications, and avoid certain foods. Having a food allergy is a serious medical condition that not only can cause a life-threatening reaction, but can also have a large psychosocial component to it. Well, let's talk about the top 9 food allergens in the United States, which are peanut, tree nut, milk, egg, wheat, soy, fish, shellfish, and sesame. Together, these allergens account for more than 90% of food allergy in the United States. So, in other words, if there are 100 food allergies, over 90 of those food allergies would be caused by one of the allergens listed on this slide. It's important to note, though, that any food can be considered a food allergy and any food can induce a food allergic response. And in fact, there are over 170 recognized food allergens. What's even more concerning is how much food allergies have been increasing. Among children, prevalence went up about 50% between 1997 and 2011, and then rose another 50% between 2007 and 2021. So food allergy is clearly on the rise, but the big question is, can we actually prevent it? So let's look at some of the key history in food allergy prevention. Over the past decade plus, the recommendations for early introduction of allergens has taken almost a complete reversal, which is important to note because you may encounter caregivers who are still following the older guidelines from their older siblings or children. Over a decade ago, the recommendation was to delay the introduction of allergens, particularly delaying egg feeding to infants until 2 years old and delaying peanuts until 3 years old. Then the landmark study in 2015 called the LEAP study, Learning Early About Peanut Allergies, changed the way that we think and understand allergy and hence the way that we counsel about the early introduction of allergens. After 2015, there was a gradual shift in the professional societies, and as you can imagine, there was some uncertainty in the recommendation with these changes. But now, professional medical societies such as the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, the Canadian Society of Allergy and Clinical Immunology, the American Academy of Pediatrics, the NIH. All of these now recommend the introduction of introducing food allergens early. And even the most recent dietary guidelines address this concept of early introduction, which shows true alignment here. Next, let's look at some research studies. And this slide shows some of the studies that actually build on this consensus so that there is research to support that early introduction of allergens is key to helping to decrease the amount of food allergies that we see. We know that the LEAP study, and we'll go into this with more detail, was the landmark study that showed how early introduction of peanut to babies who are at high risk for peanut allergy decreased the likelihood of developing a peanut allergy. But what's the science behind it? Well, part of the science is known as the dual allergen exposure hypothesis, and it starts to explain this multifactorial instance of how food allergies develop. And it proposed that early life exposure to food allergens through inflamed skin, such as eczema, leads to sensitization and a higher risk of allergy, while exposure of that food allergen through the oral route, such as eating the food, actually can promote immune tolerance and can reduce the allergy risk. So, cutaneous exposure or exposure through the skin of that allergen can cause sensitization. But if the initial exposure to the allergen is through the oral route, it can induce immune tolerance. Well, and this wasn't just one and done study with the LEAP study. These other studies that are listed on this slide are looking at how some of these principles can apply to other allergens like egg and milk protein, and also looking at some longitudinal studies that help us to assess prevalence, the determinants, and the burden of food allergy. But at this point, let's take a deeper dive into the LEAP study, which is learning early about peanut allergy. The research we're about to look at completely changed the guidance that pediatricians and allergists give to patients about when to introduce peanut foods to children at high risk for food allergy. And it all started with an observation. In the United Kingdom, where peanut introduction was often delayed in babies, peanut allergy was about 10 times more common than it was in Israel, where peanut puffs were a common snack for babies and young children. And then that striking difference really got researchers asking, well, why is that the case? Well, enter the LEAP study. This was a landmark trial that followed more than 600 infants over the course of 4 years. The babies in this study were considered high risk, meaning they had severe eczema, an egg allergy, or both. When the babies were between 4 and 10 months old, researchers split them into two groups. One group avoided peanut completely. The other group was given age-appropriate peanut food several times a week. The results, as you can see on this slide, were remarkable. For high-risk infants, those that were in the consumption group, meaning infants that were fed peanut early and often, only 3.2% of those children developed a peanut allergy, as opposed to 17.2% of children in the avoidance group developing a peanut allergy. So this is really meaningful data because as compared with peanut avoidance, peanut consumption was associated with an 85% relative risk reduction in peanut allergy. And that all lends on the dual allergen exposure hypothesis, and that early exposure to peanut from the environment and the skin may lead to sensitization, while early dietary exposure may lead to immune tolerance. Now, the LEAP study was continued in a study called LEAP On, which followed the kids from the LEAP study even longer and showed that peanut tolerance that was promoted with this early introduction of allergen could be long-lasting. So in this follow-up study, LEAP On, both the babies in the avoidance and consumption groups were then asked to avoid peanuts for 1 year at the conclusion of the LEAP study. The peanut allergy continued to be more common in the original avoidance group compared with the early exposure group. And those percentages were again remarkable. So in the original avoidance group, 18.6% of children developed a peanut allergy, as opposed to 4.8% of children in the early exposure group. But even after this remarkable data in the LEAP study, the shift in recommendations was gradual. And that's what I'm going to describe to you in the next few slides. I think it's important to know where the guidelines started and where the guidelines and recommendations are today, because you may hear bits and pieces of earlier recommendations, and I want you to know where that came from in the evolution of the recommendations that we're currently looking at. So again, immediately post-LEAP study, there was a lot of focus on what to do with these babies that were considered high risk. And high-risk babies were babies with severe eczema, an existing egg allergy, or both. And initially, there was guidance to consider screening with blood tests or a visit to the allergist in these high-risk babies. But this screening guidance has since changed, because these are the very babies, the ones with severe eczema or egg allergy, that are the babies that need early introduction the most, and waiting to get a screening by blood or an allergy visit puts these babies at increased risk. Medical professional associations began to shape their recommendations as well, saying that preemptive screening, even in babies considered high risk, was not necessary. And they extended the early introduction recommendations to include all other allergenic foods, as supported by the research that we referenced earlier and the science that we were speaking about earlier as well. These guidelines were also included in the dietary guidelines for Americans, which recognize early introduction and spoke about where around 6 months old, when that baby was developmentally ready, which means that the baby is sitting unsupported and the baby has good head and back control, has started to swallow and get rid of that tongue thrust, that it's time to introduce complementary foods that are nutrient dense, such as vegetables, fruits, and grains. And even the dietary guidelines for Americans said introduce potentially allergenic foods along with these other complementary foods. So really not delaying the introduction of these allergenic foods. And then the rest of the dietary guidelines that are outlined here are consistent with prior ones. Avoid added sugars and limit sodium to babies. Offer foods that are appropriate size and consistency and shape for a baby. Avoid foods that may be a high choking hazard, and those are notoriously things like grapes, honey, hot dogs, popcorn, nuts, thick peanut butter. And then importantly, never leaving the child who's feeding unsupervised. Supervision is always necessary. And these were steps that were provided by the dietary guidelines for Americans that really helped to build that strong nutritional foundation for a baby's growth and development. But it was in 2021 that the consensus guidelines from three major allergy organizations, QuadAI, the College of Allergy, Asthma, and Immunology, and the Canadian Society of Allergy and Clinical Immunology, came together to release these allergen consensus guidelines for food allergy prevention. And there were some key takeaways. The first one was to prevent peanut and or egg allergy, both peanut and egg introduced around 6 months of life, but not before 4 months of life. And then really what was very important about these consensus guidelines was the consensus that we should not be delaying the introduction of other potentially allergenic complementary foods. That in fact, there's a potential harm to delaying the introduction of these foods based on past observational studies. And the other big takeaway from this consensus study is that this expert consensus guidance really recommended that screening before introduction is not required, and that prior to early introduction of these foods, screening skin or IgE testing and in-office introduction is not required. However, it still may be preferred by some families but always discussing that these are the babies that we don't want to delay introduction of allergens to because they're the babies that may benefit the most from getting this allergen exposure early. Now, just because we've got all of this data and we know that the science is there, does it mean that we're following what we're recommending? And this was a study to really look at where we are now, right? And this is one of the first surveys that was measuring academic awareness and the application of US food allergy prevention among clinicians. And this really showed us that there is more education that we need to do, even to healthcare professionals, to look at how prevention guidelines and recommendations are being followed and what the awareness of these guidelines is. So this study looked at 1,257 healthcare professionals and found that there was guideline awareness that in pediatricians was about 76% reported that they were aware of the guidelines, dermatologists about 58%, family physicians about 52%, and APPs 45%. And among those participants who were aware of the guidelines, most reported using part or all of the guidelines in their practice, though reported practice patterns were variable and didn't really align with these guidelines. So the true conclusion here is that we really have to improve the education that we're giving to healthcare professionals so that they can then in turn relay that information to our families so that those that are needing early introduction of allergens the most get that information in a timely way. So, switching gears slightly and looking at risk factors for developing food allergy, because I think that it's important in looking at what true risk factors are versus other risk factors. So, one of the risk factors that I think has been agreed upon, even within the 2021 consensus statement, was that infants with severe eczema are at highest risk of developing food allergy. And then there's a potential increased risk for developing food allergy in babies with a history of mild to moderate eczema, a family history of atopy in either one or both parents, or one known food allergy that's confirmed in infancy. And I think that this is important to note because in the past, we used to really look at risk factors and have a much longer list of risk factors that we were worried about in the development of food allergy. But truly, infants with severe eczema are those that are at highest risk for developing a food allergy. But what makes this really hard is that diagnosing eczema can be very subjective. And even when looking among pediatricians and dermatologists, the severity scale of either mild, moderate, or severe often doesn't have agreement among clinicians. So, mild eczema is really where there are intermittent patches of eczema with dry, red, itchy skin rashes that may come and go, but really need minimal to no treatment. Moderate eczema is really that more consistent eczematous skin rash that is there most of the time, and the rash is typically confined to at least one area. But severe eczema is chronic, it's recurrent, it's red, it's swollen, it's itchy, it's angry looking, and it involves multiple parts of the body. And I wanted to end off with talking a little bit about the atopic march, which is also known as the allergic march, because you may hear it in discussing the development of food allergies and asthma. And this is really the atopic march is how allergic disease progresses over time. And this is a common sequence of allergic disease that often develops within individuals. And we sometimes see that in infancy, the first sign of being a part of that atopic march is atopic dermatitis or eczema. And then as we progress into early childhood, the development of food allergy, into childhood, the development of asthma, and then as adults, allergic rhinitis and asthma. And not all individuals with an atopic predisposition will follow this allergic march. And in fact, the progression and severity really vary widely. But this is a term that you may hear, especially when talking about food allergy and prevention of food allergy and looking at that relationship between eczema and the development of food allergy. So, we've talked a lot about the why early intervention and early introduction is recommended. And now I'm going to hand it over to Tiffany to talk more about how to implement early introduction of food allergens. Tiffany?
Thank you, Kelly. So we're going to outline the strategies to prevent food allergies from the maternal diet during pregnancy to early introduction of food allergens during the complementary feeding period. Now, there's been a lot of research done on supplementation, of course, during the prenatal period, and some supplements are recommended at baseline for a healthy pregnancy. But there was studies recently done on vitamin D during the prenatal and postnatal period, omega-3 fatty acids, even probiotics, to see if there was any opportunity to have an effect on preventing the development of a food allergy. And unfortunately, these supplements do not seem to have an effect on the development of a food allergy. There doesn't seem to be a single nutrient that can prevent these atopic diseases, this food allergy. And there's also been so many papers done on maternal diet during pregnancy and maternal avoidance of common food allergens during pregnancy and lactation for the purpose of preventing a food allergy in infants is not recommended by national or international guidelines. Now, Kelly reviewed the NIAID guidelines, the dietary guidelines for Americans, the 2021 consensus guidelines, and nowhere in those guidelines does it say that the mom should be avoiding allergens to then prevent food allergy. If a mom does have a food allergy or is managing a food allergy herself, of course she should be avoiding peanut or avoiding the allergen in her diet for her own self and health and safety. But we want to make sure not to promote these avoidance, these elimination diets for mom during this period of building, this period of growth, because they may be missing out on some really important nutrients. So we want to make sure that we are reiterating the importance of a pregnant or a breastfeeding woman, lactating woman, to have a healthy, balanced diet and to not restrict important nutrients during this time. And as far as preventing food allergies go, it doesn't seem to mean that there should be additional supplementation above what is already recommended during a healthy pregnancy. Now, when we're talking about things to add in, what is composed or what comprises of a healthy diet, we can look to the maternal diet index. Now, researcher and dietitian Karina Venter created and studied the maternal diet index, which included weighted measures of intake of vegetables, yogurt, fried potatoes, rice, grains, red meat, pure fruit juice, and cold cereals. Now, after reviewing some of the data, it looks like vegetables and yogurt were associated with the prevention of any allergy. And this might be because of some pre or probiotics present in the vegetables or in the yogurt, maybe some of the fibers and some of these other micronutrients in these two groups. And it did show that consumption or excessive consumption of fried potatoes or diets composed primarily of rice, grains, cereals, processed fruit juice, and red meats may be more at risk of developing a food allergy. Now, we don't want to say that, mom can't have a burger and fries during her pregnancy, especially in the beginning. They may be really sick. There may be this hyperemesis, might be vomiting, morning sickness. And so cold cereals or simple grains and fruit juice may be what mom is able to tolerate. But we want to emphasize that if there's an opportunity to choose to add in additional vegetables or to choose to reach for that yogurt, there may be some benefits down the road. This is the first study that has shown associations between an index of maternal diet intake during pregnancy and multiple offspring allergic diseases, which is really groundbreaking, and I'm really excited to learn more. So as we move from the maternal diet to the infant diet, we're going to start from the beginning. Now, when the infant is born, there's really two ways to feed the infant, whether it's through breastfeeding, human milk, or formula fed, or a combination of both. Now, we're going to be addressing both feeding mechanisms here. And we're going to start off with exclusive breastfeeding. So, exclusive breastfeeding as a primary measure to prevent food allergies is inconclusive, though may be protective against eczema or infant wheeze. So, breastfeeding human milk, it is a wonderful, nutritious first food for the baby. It's comprised of so many micronutrients, and the benefit, the additional benefits of mom, bonding with the baby, it's not lost here. So we do promote breastfeeding, if possible, if mom is able to. Now, but as a primary measure or as a strategy to prevent food allergy, it is inconclusive. And there is no conclusive evidence that partially or extensively hydrolyzed formulas can reduce the risk or prevent allergic disease in infants at higher risk of developing food allergy. So Kelly mentioned which infants are at higher risk, those that have moderate to severe eczema. These little ones that are freshly born may not have been already diagnosed with an egg allergy. That's the other risk factor. But so these infants that are at higher risk of developing a food allergy, feeding them extensively hydrolyzed formulas has been shown inconclusive to prevent a food allergy, development down the road. So we do not recommend routinely using these formulas specifically for prevention of a food allergy. If the baby requires these specialty formulas for another reason, maybe they have a cow's milk allergy or have procticulitis, and they may need these extensively hydrolyzed formulas, and of course, these are resources that are available. But we just want to say here that exclusive breastfeeding and or exclusively hydrolyzed formulas are inconclusive in preventing a food allergy. And since we talked about maternal supplementation, we want to talk about infant supplementation too. And there are two key supplements that have been studied in infants. And we'll start with the omega-3s. Now, there was one study that was performed in infancy to study the effect of omega-3 fatty acids, fatty acid supplementation. This is 390 milligrams per day in high-risk infants on childhood allergy outcomes. And unfortunately, this trial did not find any benefit to supplementation. And then there was a study on high-dose vitamin D supplementation, and this study also did not prevent allergic sensitization, allergic diseases, or wheeze during the first year of life. And in contrast, we observed an increased risk of milk allergy in infants that were randomized to higher vitamin D supplementation and an increased risk of allergic sensitization in infants with high cord blood vitamin D status, indicating that there is a possible adverse effect of high concentrations of vitamin D. So we talked about exclusive breastfeeding in the previous slide. Those infants, it is recommended to take a vitamin D supplement to make sure that they are meeting this gap in their nutrition. But when we're talking about high dose vitamin D supplements or supplementation, we want to note here that there may be adverse risks. It may actually be associated with an increased risk of developing a food allergy. So when we're talking about supplementation during the prenatal period or postnatal period or in infants, we want to make sure that we are involving a physician in these conversations to see what baby and dietitians to see what babies, really need. And of course, these babies are going to grow older, and soon, around 4 to 6 months, and when developmentally ready, they will transition to solids. So this slide is a review. Kelly mentioned this slide earlier. This is the 2020-2025 dietary guidelines for Americans. So I'm just bringing it back here. Because as the infant is ready to transition to start to solids around 6 months, as we said, when developmentally ready, introduce nutrient-dense complementary foods. These are the veggies, these are the fruits, these are the grains, these are the proteins. But we also want to recognize here that the second bullet says introduce potentially allergenic foods along with these complementary foods. So we're talking peanut, we're talking tree nut, we're talking egg. Um, and of course, avoiding added sugars, limiting sodium, offering foods that are appropriate size, consistency, and shape for their age and stage, avoiding foods that may be a choking hazard. And you'll see here that on the slide, it says peanut butter. So we know, or hopefully we know, that whole peanuts are a choking hazard for the infants, but even a spoonful of creamy peanut butter can be a choking hazard for the infants. So we'll talk about that in a second. And of course, just making sure that we are watching watching the child during this feeding period, because even if we're serving age-appropriate items, that we just want to make sure that there is supervision to watch for choking, but also allergic reactions. So starting with the veggies, infant cereal, and fruits, and once these foods have been successfully added into the diet, then moving into the foods that can commonly trigger allergens. And this is because we want to make sure that the infant is ready to eat, is showing signs of interest, is able to, you know, open their mouth and hold the spoon and really engage in the feeding process. And feeding babies is such hard work that you want to make sure that you have a little experience under your belt before you start introducing some of these higher risk foods that could potentially cause an allergic reaction. So let's look at how we can introduce some of these foods safely. And when we're looking at how to introduce peanuts safely, I already mentioned we are not going to be using whole peanuts in this cohort, but creamy peanut butter, even if you're using this creamy natural peanut butter, you want to make sure that you're thinning it by mixing it with breast milk, with formula, or water to make sure that the consistency is more appropriate for the little one. You could start with just a taste, offering a small amount on the tip of the spoon. And if you're doing peanut for the first time, you could offer a peanut and then continue feeding another food and just, watching for a reaction. These reactions could happen immediately or up to 2 hours after giving this peanut containing food. So just keeping an eye on your baby for that period, immediately up to 2 hours. Maybe considering what time of day you're feeding the infant. This may mean serving it at breakfast instead of serving it at dinner, just so that you have a little bit of a period where the baby is awake or in your field of sight, so you can watch for a potential reaction. So what does a reaction look like? Allergic symptoms can include skin rash, hives, vomiting, swelling of the tongue or lips, coughing, wheezing, and just like generally starting to look sick. Now, if your baby has a reaction, we want to stop feeding the peanut containing food until we want to make sure that you contacted your healthcare provider and told that it is safe to do so. And contact your healthcare provider and make sure that your baby is receiving treatment if needed. And if your baby is having trouble breathing, then call 911. Now, keeping in mind this is rare. Anaphylaxis is rare in infants, but in food allergy, we never say never. So if baby's having a reaction, stop feeding, seek treatment. If the baby is not having a reaction, then we can move on to next steps. But I did sidestep to talk about allergic reactions here, but let me just jump back to talk about the other ways we can serve peanut for the baby. And that does include peanut flour or peanut powder that you can mix into a puree your baby already eats. And there are some commercially available puff snacks that are made with peanut or ready to eat immunobutters. And these puffed snacks was what really sparked the idea of the LEAP study. These are those Bamba snacks that are commonly eaten in Israel. And so they are available in the US, or a version of that's probably available in a store near you. So these are the three ways that you can use to introduce. But of course, it doesn't stop there because if the baby doesn't have a reaction, then we want to continue to feed the baby peanut-containing food 2 to 3 times per week. So caregiver introduced oatmeal, introduced green beans, and the pineapple core if you're going the baby-led weaning route. And now you're ready to move on to peanut. You fed peanut, there's no reaction. We want to make sure that this is continuously added into the diet. We want to make sure that you are continuously engaging the immune system. It's when families start peanut or start an allergen and then they stop feeding when they can be more at risk of developing a food allergy. So if the baby has a reaction, of course, you stop. If the baby does not have a reaction, then you want to make sure that you're continuously keeping it in the diet because if the baby has peanut at 6 months and then isn't fed peanut again until 8 months, the body may think, "Oh no, that was an invader. We're not seeing that regularly. Maybe next time I eat it, I should attack that." So we want to make sure to regularly engage the immune system. The guidance is 2 teaspoons 2 to 3 times a week, but we really don't want to medicalize this for the dad, caregiver. They're already dealing with so much during this period, reaching milestones. Doctor's visits are packed with questions. We want to make eating fun and just like part of the regular day of the dad, caregiver, baby. And so it does pay to be persistent. Some babies may not show interest in solid food at every eating, but continuing to offer food consistently is the goal. One meal, the baby may lick the spoon. One meal, the baby may eat the entire bowl. The next day, the baby may not want anything at all. So it can be variable in their intake, but we just want to continue offering it and we want to continue to expose the baby to these foods once they're added into the diet. Now, once peanut butter or peanut is incorporated into the diet, we want to add in foods according to the family preferences and cultural practices. This helps to promote diet diversity. So, diet diversity is defined as the number of different foods or food groups consumed over a given reference period. Now, no matter how this is measured, whether it's 5 foods or 20 foods, or which foods you include, like ones from the Mediterranean diet or only plant-based foods, a variety of whole foods is beneficial. And diet diversity consistently shows a reduction in allergy outcomes. So let's take a look at what that means. So let's see what that means in action. And I'm going to bring up the dietary guidelines again for the third time in this session, but we want to encourage infants and toddlers to consume a variety of foods from all food groups. This helps to promote diet diversity and transition to a healthy diet pattern for life. We want to include foods that are rich in iron and zinc, particularly for infants that are fed human milk or breast milk. We want to make sure that those that are exclusively breastfed until this point are also receiving an appropriate vitamin D supplement, making sure to avoid these high levels, these high concentrations of vitamin D, as I mentioned before. And, working with a doctor or a dietitian to determine the appropriate supplementation. And then for those infants receiving infant formula, it's likely they're meeting their needs through fortification anyway. So we want to aim to introduce all of the potential allergens within the first year. And if you're starting around 6 months, you've got plenty of time to do that. But we want to make sure that we are not only introducing it once and early, but that we are introducing it often. So this is a key phrase that you'll hear a few times, but early, eat often. And we talked about ways to serve peanuts, infant-safe forms of peanut, comes traditionally in nut butter form. And there are a lot of tree nuts out there that also can be commercially found on the shelves as a nut butter. So you will see almond butter and cashew butter and walnut butter. And these are really easy opportunities to thin with water and breast milk or formula. It can be mixed in a previously tolerated puree. And then you have this big jar so you can remind yourself to continuously keep it in the diet. There are a ton of tree nuts out there, but focusing on cashew and almond, um, pecan, pistachio. These are some of the more common tree nut allergies. And we want to make sure that, again, once we introduce them, we're not just crossing it off the list, but that we are regularly keeping it in the diet. Now, when we're moving through some of the other legumes, we already talked about peanut, but if we're talking about how we can introduce soy, there are so many products on the market that contain soy exclusively, like a soy milk or a smashed or a tofu. Now, tofu could be served in strips. You could incorporate it as part of a smoothie or a part of a puree. There are soy yogurts and soy milk that you could also look into introducing. Just making sure if you're choosing a soy yogurt, and this goes the same for cow's milk yogurt, but making sure that it's plain and unsweetened because you don't want to be adding in all these extra sugars for these 6-month-old babies. But soy is a great first food, and if tolerated, can incorporate so many different ways in a scramble or in a stir fry as the baby gets older, moving into toddlerhood. And even edamame, my kids love popping the beans out of the edamame pods now. And if you are serving milk, a cow's milk, now the babies that have had cow's milk formula may already be showing tolerance to cow's milk. So an unsweetened cow's milk yogurt is appropriate here. Soft, low sodium cheeses like mozzarella. Preparing infant cereal with cow's milk. Now, I will stop and say here, just as a reminder, it's okay to use cow's milk in a recipe like mixing the infant cereal or making a puree, making a smoothie. But we don't want to replace breast milk or human milk or a formula with cow's milk until age 1. So it's okay to use it in small amounts in recipes, but we don't want it to be a replacement beverage until the baby is older. And then wheat is another good, easy first food for the infant. There are wheat-based infant cereals. Babies like to hold big pieces of bread. I can think back to my son's first birthday, and obviously this wasn't the first time that he had it, but I have a picture of him holding up a big bagel because he just like really loved holding and being able to work with that big piece of bread. And as they get older, maybe crackers or pasta, different shapes of pasta. I know my kids like to pick the different pasta shapes, and there are so many different brands out there now that you could use that to incorporate some other diet diversity as well. And when we're talking about things that need to be cooked for little ones, like eggs, or that need to be cooked for adults, like eggs, we want to make sure they are also cooked for the little ones. So whether you're choosing to serve scrambled eggs or a hard-boiled egg or egg strips or even these infant pancakes, we want to make sure that it is well cooked because you don't want to have a foodborne illness situation when you're trying to decide if this baby is having a food allergy reaction or vomiting because they're having salmonella. And same thing goes with fish or shellfish, making sure that we're not serving raw fish to a baby. Want to make sure that it is cooked whitefish or cooked salmon or even fish sticks, lobster bisque, making sure that we are serving fish or shellfish in the cooked form because we don't want to make sure we want to make sure there is no foodborne illness. So just, trying to add in foods from different groups, from different flavors, and of course, keeping them all age appropriate. So let's just take a look at the impact of diet diversity. And I really love these two graphs because it really tells such an incredible story. On the first graph, we see food diversity at 6 months. So with each additional food added into the diet around 6 months, this reduced the risk of food allergies by 10 years of age by 11%. Now, I should note here that the kids weren't eating, 150 foods or even 50 foods. It was really 6 to 11 foods around 6 months of age. So once a baby starts to eat, it doesn't mean you need to add in a new food every single meal and make sure that they're, packed with diet diversity. It just means trying to incorporate new foods at breakfast, maybe new one at dinner, maybe new one the next day at lunch, so that the baby can be exposed to all of these flavors and fibers and nutrients and pre and probiotics to potentially reduce the risk of food allergy. And then on the second graph, you see food diversity at 12 months. Um, what we're really actually talking about the number of allergenic foods, these potentially allergenic foods that and with each additional food allergen, reduce the risk of food allergies by 33%. So adding in additional allergens, so not just stopping at peanut, but working through egg and soy and wheat and working through the different classes of tree nuts can really reduce the risk of food allergy. So what's the takeaway here? And this is, this is one study, but the takeaway here is that 5 foods is better than 4 and 10 foods is better than 8. And, we don't want to force the baby to eat. I know there's a lot of programs out there that are, 100 foods under one. And like that's such an amazing goal to promote this diet diversity, but we don't need to force the baby to eat 180 foods in by age 9 months. Follow their lead. It's very, very hard work. If you're struggling to get foods in, just know that each additional food has an impact, and offering the foods consistently can allow your baby to explore these new foods, explore these textures, explore these flavors, and potentially reduce allergens or reduce food allergy. And so we're going to go one step further just to show some additional support. And there was a systematic review that reviewed 17 papers that showed that diet diversity prevents food allergy and can also reduce other allergy outcomes. And this is super critical because infants transition to family foods, with higher protein and higher fiber content, and all of these things can start to promote overall microbiome health. So, what is the dietitian's role in all of this? And I'm so glad that you asked. There are so many ways that we can engage with the new parents, caregivers of these infants, but there are a few things specifically we can do to help prevent food allergy. And the first thing is to help translate these guidelines into practical steps. We talked about the dietary guidelines for Americans. We talked about the 2021 consensus guidelines. We talked about the 2017 NIAID guidelines. AAP, so many professional organizations come out with different guidelines. They're updated and in different intervals. And we need to take the role of being able to translate these guidelines into practical steps for a mom. Great, this document is 40 pages. What do I need to do? And the outcome or the output really is to introduce peanut. This, as we saw in the beginning, the guidelines used to be so different 20 years ago, and transitioning to these new guidelines is it can be huge. We were told to avoid peanuts, or my parents were told to avoid giving peanuts until age 3. And now when I tell my mom, who's a grandmother now, she's shocked that these guidelines are different. So healthcare professionals, new moms may be also experiencing this hesitation. And so we can step in as the expert to help them translate these guidelines into practical steps and offer encouragement during this food introduction stage. And of course, we can help alongside the pediatrician, but assessing risk of developing food allergy, this is egg allergy or eczema or both, those are the ones at higher risk, encouraging conversation with the pediatrician. I know those visits are so packed with questions and milestones, but making sure that we are asking the appropriate questions for that baby and for your baby, and then helping to confirm this developmental readiness, including these gross motor skills, oral skills, fine motor skills of the infant, so that when that baby is ready to eat, we are ready to offer the food, to offer the solids for that little one. And I wanted to highlight a few resources here. We have a whole toolkit that's available for free to download on how to introduce peanuts safely. These can be used for you, of course, if you have a little one at home, but they can also be used in your clinic or in your private practice. And it goes through different recipes. I know we talked about a couple ways to introduce peanut. It goes through a few recipes. It goes through some feeding tips, how to identify if the baby is ready. So these are really valuable resources at foodallergyprevention.org. And on our main website, we have free courses and training for those schools, food service workers, other healthcare providers, dietitians, patients, parents. These help those that are helping to manage food allergy. So there may be parents that are looking for prevention tips because they have a child with food allergy already. They may have a food allergy themselves. So you may be working with two cohorts for prevention, but also in management. And we just wanted to be able to share that we offer resources for both. And with that, I will close. Kelly and I thank you so much for being here today. Please feel free to reach out to education@foodallergy.org if you have any questions. Thank you.